Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Respiratory Issues in the Older Adult, Episode 2, Pneumonia. After viewing this episode, participants will understand the pathophysiology of pneumonia. Participants will review the abnormal physical exam findings and symptoms seen in geriatric patients with pneumonia. Finally, participants will review treatments for pneumonia in the field.
Pneumonia is best summarized as either an infection or an inflammation in the lung parenchyma. It's best to think about this as kind of the spongy part of the lung, and this is full of some debris, which is some combination of a pathogen like a virus or bacterial pathogen, and the associated inflammatory cells that our body uses to fight these pathogens. Older adults catch pneumonia the same way a younger person would catch pneumonia. Is typically an inhalation or aspiration of some infected particles. There are the rare occasions when people get pneumonia from a systemic infection where an infected organism ends up in the lung through the bloodstream.
Pneumonia is an infection of the lungs, originating from debris in the parenchyma, or the functional portion of the lung. Older adults are more susceptible to pneumonia due to a decreased immune response.
Most of the hospital admissions for respiratory tract infections in an older population are typically in the wintertime, especially December, January, February. Those are when most of the influenza infections are discovered, and influenza can result in a pneumonia type of illness, and even true influenza can result in pneumonia because of the weakening of the immune system that the patient has.
In the geriatric population, pneumonia is more common due to the increased incidence of aspiration associated with possible cognitive decline or confusion, and the increased difficulty in clearing secretions, with also a waning of the immune system.
The response of this is something which can either be well tolerated by the patient and sometimes very poorly tolerated. That region of the lung doesn't participate in gas exchange because it is, think about the sponge being full of these abnormal cells. And there's also a lot of inflammatory response that makes the body systemically ill frequently as well. And so the severity of your pneumonia is related to a lot of your comorbidities, meaning do you have underlying alcoholic disease, heart disease? Do you have some underlying lung disease that decreases your pulmonary reserve and your ability to tolerate these lung infections? People who have weakened immune systems are typically much more vulnerable to not just the routine types of pneumonia, but a whole bunch of additional types of infections of the lung.
Pneumonia will present differently from individual to individual. The severity of the clinical response is influenced by the presence of comorbidities including underlying alcoholic disease, heart disease, lung disease, and weakened immune response.
I tend to think of a geriatric patient may have more blunting of their symptoms compared to a younger patient. It may be a more subtle presentation than you would see in a younger patient. An example would be, I saw a patient in the emergency room when I was a resident who presented with falls, and the root cause of her presenting with falls ended up being a pneumonia.
Well, I think there are four cardinal symptoms of pneumonia, and those are cough, fever, shortness of breath, and sputum production. You certainly don't have to have all of these symptoms, and there are many other things you might have as well. You can have shaking chills, you can feel systemically ill, and you can have one or more of these symptoms or none of these symptoms. The cough may be more subtle, body's response may be more subtle, and they may just have a generalized illness that isn't, frankly, quite clear, especially in the pre-hospital setting.
You would think of the normal exam findings of pneumonia: increased shortness of breath, cough, but they also may present with some confusion or mental status changes. And that's more common in the geriatric population.
The four major symptoms of pneumonia include fever, cough, shortness of breath, and sputum production. Additional symptoms include sweating, shaking, chills, chest pain, headache, muscle pain, and fatigue. It is common for older adults to present with mental status changes and less traditional symptoms than a younger individual would present with.
The first thing you would find is on inspection, they can be in some distress. They can be tachypnic, meaning breathing fast. Sometimes you just simply observe a cough, especially a productive cough, which is pretty suspicious in and of itself. On percussion of the chest, you might appreciate some dullness, suggesting a consolidation of some part of the lung. And then on auscultation, you would listen to the lung and you would hear some adventitious lung sounds, typically crackles or rails in certain parts of the lung. Those would be probably the clinical exam findings, and there's other things that would be meaningful, especially laboratory findings with an elevated white blood cell count and radiographic findings with a shadow on an x-ray. Those things would all be very supportive.
On inspection, EMS should be looking for a variety of complaints like distress, difficulty in breathing, or cough. Percussion may yield dullness, evidence of a consolidation of the lung. On auscultation of the chest, you may hear crackles or rails. A chest x-ray and laboratory findings will help confirm pneumonia and rule out other possibilities.
Well, the foundation of treatment of pneumonia is going to be antibiotics. The pre-antibiotic treatment of pneumonia led to some really dismal outcomes. So antibiotics are and will be the foundation of care, but there's a lot of additional things that are done which are primarily supportive in nature. Oxygen if it's needed, IV hydration if it's needed. We monitor for respiratory failure using either non-invasive support, being CPAP or BiPAP, and sometimes invasive mechanical ventilation. All these things are being done while the pneumonia is being treated with an antibiotic.
The antibiotic treatment is effective. However, the caveat is that older patients may die more frequently of pneumonia, and that's in part because of their complications of the treatment of pneumonia and their other comorbid diseases, such as heart failure or COPD, that accompany the pneumonia that they have.
Field treatment for pneumonia is limited. EMS should complete a thorough physical examination, medical history, and establish an IV. Unless the patient's respiratory distress is directly related to COPD exacerbation, bronchodilators and CPAP will have little effect. After viewing this episode, participants will understand the pathophysiology of pneumonia. Participants will review the abnormal physical exam findings and symptoms seen in geriatric patients with pneumonia. Finally, participants will review treatments for pneumonia in the field.